Okay, I'm Annette Rigby, and we're going to start with the endocrine section. Now, yesterday, we already started talking about the endocrine section when we mentioned words like aldosterone and ADH. So we're going to review for just a minute. Aldosterone is a steroid, and we know that the normal action of aldosterone is to make you retain what? Sodium and water, okay? So I told you if you want to get those questions right with aldosterone, you've always got to think about sodium and water. Now, like with any other chemical in my body, I can have too much or I cannot have enough. So if I have too much aldosterone, I'm going to retain a whole bunch of what? Sodium and water. So I'm going to go into a fluid volume excess, okay? Now, I want you to tell your friend, what were those two diseases where you have too much aldosterone? They were Cushing's and hyperaldosteronism. That's right. Well, what happens in the body if I don't have enough? Okay, then I'm going to start losing sodium and water, and I'm going to go into a fluid volume deficit. That's right. Now, tell your friend the name of that disease. Addison's. That's right, Addison's. Yesterday, we also talked about ADH, and we know that that is antidiuretic hormone, and we said that the normal action of ADH is to make you retain or diurese. Which one is it? It makes you retain. That's right, it makes you retain, and it makes you retain what? Water. Just water when we think about ADH. And just like any other chemical, I can have too much or I can have not enough. So think about it. If I have too much ADH, am I going to retain or diurese? I'm going to retain. That's right, I'm going to retain. And I retain what? Water. That's right, I retain water. So when I do that, I'm going to go into a fluid volume excess. And we said this was called SIADH. Remember what we said? Too many letters, too much water. And we said normally when patients go into a fluid volume excess, their urine output does what? It goes up. That's right. Normally when you go into a fluid volume excess, your urine output is going to go up to help them get rid of that fluid. But is that happening here? No, it's not going to be happening here. It doesn't happen with too much ADH problems. So what is their urine output doing? It's decreasing. That's right. It's going down. So with SIADH, I'm going to worry about a fluid volume excess. So take just a second and go over SIADH with your friend. Now remember when we were talking about SIADH, we said we were retaining water, 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 right? So our blood is going to be very dilute. Okay, your blood is very dilute when you have SIADH. Now with SIADH, my output is decreasing. So when I do that, my urine is going to be concentrated. And we said concentrated makes numbers go up and dilute makes numbers go down. And what were those three things we talked about yesterday that related to those things? We said it was specific gravity, sodium, and hematocrit. Those are the three things we're talking about. Now, let's look at the opposite of SIADH. So we're going to talk about diabetes insipidus, okay, DI. So if I don't have enough ADH, I'm going to retain or diurese. Going to diurese. Remember, we had you circle that D in diurese, that D in DI. So I'm going to be losing water. Therefore, I'm going to go into a fluid volume deficit. Can I go into shock? Yes. Yes, I can. So if I'm losing all of my water out of my vascular space, is that going to leave my blood concentrated or dilute? It's going to leave it very concentrated, right? Very concentrated. Now, normally when patients go into shock, their urine output goes down, right? To help them to hold on and to conserve what little bit of volume they've got left. Well, with the DI person, they're in shock, but their urine output is increasing. They're diuresing, okay? They keep putting out these large volumes of dilute urine, Could that kill my client? Absolutely. So with DI, I'm worried about severe fluid volume deficit or shock. Now, remember yesterday we said that the ADH likes to live in the pituitary, lives in the pituitary. And we gave you some key words for you to think about when you're talking about potential ADH problems. Tell your friend what those key words were. We said head injury, craniotomy, transsphenoidal hypophysectomy, and sinus surgery. Those are the key words that we gave you. We said that ADH problems are usually secondary to something else. Like, if I'm in a car wreck and I have a bad head injury, you're going to be doing those neuro checks, right? You're going to be monitoring my ICP. But if I start putting out these large amounts of dilute urine all of a sudden, you're supposed to be alert to that because what disease could I have developed? Diabetes insipidus, right. Could I go into shock and die? Yes. But does this type of diabetes have anything to do with your blood sugar at all? No, does not. Okay, let's look at your handout. We're going to talk about some thyroid and some thyroid problems, like the thyroid gland. We know that the thyroid produces 3 hormones, T3, T4, and calcitonin. Now, we mentioned calcitonin yesterday, and we said that calcitonin makes your serum calcium go down, right? It makes it go down. We said that calcitonin decreases serum calcium by taking the calcium out of the blood and putting it back into the bone, right? And it can be given as a drug, calcitonin or calcimar. So, what disease is that going to be good for? Would this drug help treat? Osteoporosis. That's right. Y'all did listen yesterday. Y'all were doing good. Now, what do we have to make these hormones? Iodine. Where are we going to get this iodine from? Foods we eat, right? And we have plenty of iodized salt in this country. We don't need to add any iodine to our diets. So what I'm talking about here is the dietary iodine, okay? And we're going to emphasize that because the dietary iodine has a totally different action than the drug iodine. And we're going to talk about that in just a minute, how they have 2 totally different actions. Now, we know that those thyroid hormones give us what? They give us that energy. That's right, they give us that energy. Well, if you understand that, then guess what? You already understand hyper and hypothyroidism. Because if I'm hyperthyroid, I'm going to have too much energy. That's right, too much energy. And if I'm hypothyroid, then I'm just not going to have enough. Just not going to have enough. Just that simple. So let's look at hyperthyroidism, too much energy. We see it's also called Graves' disease. Let's look at our signs and symptoms. Client's nervous. What's going to happen to their weight? It's going to decrease, right? It's going to decrease. Other signs and symptoms that we see, they're sweating, they're hot. They have all of this increased energy, that increased heat production, so that's why they have that intolerance to heat. That's why they're hot. Okay, the next thing it says is exophthalmos. Well, what is exophthalmos? That's when their eyes do what? They bulge. That's right, their eyes are bulging. And we hope that that does not ever happen because if it does, it's irreversible. You know, you've seen those pictures in your textbook and their eyes look like they're about to pop out. So we need to catch this disease early to try to prevent that. What do you think is going to happen to their attention span? Is it going to increase or decrease? It's going to decrease. These patients are wild with energy and they just can't focus on anything. Their appetite, what's it going to do? It's going to go up. Think about that. Everybody's dream, right? Eating more, and what's your weight doing? You're just losing it, okay? Just losing weight. Everybody's dream. Well, they're irritable. Now, if you had to pick, would you say that their GI tract is going to be fast or is it going to be slow? It's going to be fast, right? We're trying to pick the most obvious way that it could be because in the real world, we know our body can do just anything. We're just trying to pass that test. What's going to happen to your blood pressure if you're hyperthyroid? It's going to go up. Right. I'm wild with energy. My blood pressure, my heart rate goes up. What's going to happen now to the workload on my heart? It's going to go up. It's going to increase. Could I get into some heart trouble? Absolutely. Could I have an arrhythmia or a palpitation? Yes. Now, what's going to happen to the size of the thyroid? It's going to get bigger. And anytime you have an organ that is working overtime, what happens to it? It enlarges, it gets bigger, it hypertrophies, it's working overtime, making more hormones. Now, let's look at how we're going to diagnose hyperthyroid. If you were to draw a serum T4 level on this client, would it be increased or decreased? It's going to be increased. That's right. It's just one of those thyroid hormones. It's one of the ways that they diagnose this. They check those blood levels. Again, it's one of the ways that they'll diagnose this. They'll check their blood levels. Another way that they diagnose it is they do that thyroid scan. So they send the patient to x-ray and they see this big glowing thyroid and they're like, yep, I bet they've got hyperthyroidism. So let's see, the client has to discontinue any iodine-containing medications 1 week prior to the thyroid scan. So 1 week prior to the thyroid scan. Now let's look at our treatment. They've got these antithyroids like PTU, Tapazole. They're going to stop the thyroid from making that thyroid hormone. So we use these pre-op to stun the thyroid, and we want the client to become euthyroid, which means what? Normal. Because you know, anytime you see the letters E, U in front of a word, that just means normal. Now, here's the drug iodine that I was talking about earlier. Remember, drug iodine is different than the iodine that you eat. They have two totally separate actions. So you'll see on your handout it says that the action is to decrease the size and the vascularity of the gland. That's why they give these drugs pre-op, to decrease their chance of bleeding. Again, sometimes they'll give these drugs pre-op to your patients to decrease their risk for bleeding. Y'all, your endocrine glands are very vascular. They're very vascular. So we see some examples there are potassium iodine, Lugol solution, and SSKI. We see it says that you've got to do what? Give it in milk or juice and use a straw. Anytime you see a drug that it says for you to use a straw, then it must do what? Stain their teeth. That's right, stain their teeth. Now, let's look at our beta blockers. Inderol, that's one. What's the fancy name for Inderol? Propranolol. That's right. But you don't have to know both of them, because on the test, guess what? They're going to give you both of those names. Now, listen to me for just a second. Don't write this down. But think about this for just a minute. Propranolol, atenolol, metoprolol, labetalol. What do they all have in common? LOL, right, that law behind it. And that's one way that will help you classify your drugs when they all start sounding the same. So when you see LOL, that should signal you, hey, that drug is obviously a beta blocker. Now, we're going to talk about how beta blockers work. They decrease myocardial contractility, so they're going to decrease your cardiac output. They're going to decrease my heart rate and my blood pressure. Well, is that good for my patient who has hyperthyroidism? Absolutely yes, okay? But aren't there a whole lot of other cardiovascular drugs out there that they could have used that are going to do the exact same thing? Yes. Well, I wonder why they pick beta blockers. Well, guess what? Beta blockers will help to decrease that anxiety. So write that down. They will decrease your anxiety. Talk about that for just a second. Maybe you know somebody who had to give a speech, or maybe you had to give a speech. You were nervous, okay? Go to the doctor and you're like, look, I got to have something to calm me down because I am just so scared. I cannot get up there and do that speech. So the doctor says, okay, I'm going to write you a prescription. Here's 10 milligrams of Inderol. Make sure you take it about an hour before you're going to give your speech. Now, let's talk about how they work and how they can help you if you're nervous or if you're anxious. Beta blockers won't let you release what? That epinephrine and that norepinephrine. We know what those are. They're those fight or flight hormones. That's what you get that surge of, right? When you're scared, you get that surge of that epinephrine and that norepinephrine. And when you do that, your heart rate's going to go up, right? Your blood pressure's going to go up. And beta blockers block that surge of that epinephrine and that norepinephrine. So guess what? You remain calm. Okay, now I know what some of y'all are thinking. You're like, I'm going to get me some of that before I go take my test, so I won't be quite so scared. Well, you better not, because we just said that beta blockers are going to decrease that myocardial contractility, which some people can handle, some people cannot. When you decrease my myocardial contractility, what'd you just do to my cardiac output? You decreased it, right? You decreased it. When you decreased your cardiac output, what's going to happen to your head perfusion? It's going to be decreased also, okay? So I don't think you want to be messing with your head perfusion on the day you take state boards, okay? Okay, good. Okay, so let's stop and do a critical thinking exercise here. Let's say it's 3 o'clock in the morning, and I'm going to go to the Super Walmart because I'm bored, I can't sleep. All those nursing students are up making so much noise. They're having a big drinking, not a drinking, they're having a big study party, and they won't shut up. They're just being so loud. So I park my car in the very back of the parking lot, and I go into Super Walmart, and I'm shopping. And after 2 hours of shopping in Super Walmart, I come out with all of my stuff, and I go back to my car that's parked way back in the back of the parking lot, and there's a big man standing there waiting on me. And I don't know why, but he's standing there by my car. What am I going to get a surge of? Okay, those fight or flight hormones, right? My epinephrine, my norepinephrine, which is going to make me do what? Pick up my buggy and make sure I run as fast as I can, because he's not going to get any of my Walmart stuff, right? I spent 2 hours in there shopping for it. But what if I was on a beta blocker? If I was on a beta blocker, then what would I do? Well, I'd probably just walk right on up to that man. I'd be like, hey, how you doing? Okay, because am I going to get that surge? No, okay? We're going to talk it out. We're going to talk about all the deals I got at Walmart. Now, let's talk about this for just a second. There's a person out there in the world that needs to know when they start feeling these symptoms, and I want you to listen to these symptoms. The person's nervous. They're shaky. They're jittery. They're cold and clammy, and their heart's just beating really fast. See if you and your friend can figure out what those are signs and symptoms of. What you think? Hypoglycemia, right? Hypoglycemia. So we're going to see here that our diabetics never should take a beta blocker because they're going to hide those signs and symptoms of hypoglycemia. Okay? It's going to mask those signs and symptoms of hypoglycemia. Beta blockers, we've already said, are not going to let you release that epinephrine and that norepinephrine. And asthmatics, they should not take beta blockers because it actually could precipitate an attack. Now, we're going to look at the radioactive iodine. With radioactive iodine, 1 dose is usually all that's needed, and it's given PO either in the form of a liquid or a tablet. So it's going to destroy those thyroid cells. When you destroy my thyroid cells, am I going to be making as many thyroid hormones as I used to? No, I'm not. So here I'm going to become hypothyroid. And hypothyroidism is expected here. Since I was expecting it, is it an adverse effect? No. Now, they need to follow those radioactive precautions. This is totally different than the radioactive precautions that we talked about in the oncology section. Okay, so the 2 major things that you have to remember here are that you need to stay away from babies for 24 hours and don't kiss anybody for 24 hours unless it's somebody you don't like and you want to radiate them, okay? Now, on your handout it says we've got to watch for a thyroid storm. thyroid storm, thyroid crisis, thyroid toxosis. They're all the same thing. It's just hyperthyroidism multiplied by 100. Well, when I think about that, could that be an emergency? Yes. Could I have a heart attack? Yes. It's time that I'm going to be going to the ICU. Now, let's make something clear. I do not have to have had radioactive iodine to go into a thyroid storm. Anybody who has hyperthyroidism can go into a storm at any time. But why are we talking about it here? Okay? Because when you give me radioactive iodine, what did you say it was going to do to my thyroids? Destroy it, right? It's going to destroy them. So I've got this little bitty piece of thyroid left, and he's looking at the blood, and he's saying, where'd all those thyroid hormones go? So then this little bitty piece that's left thinks it has to do what? Make more, okay? So that's why you'll see it says, could be a rebound effect post-radioactive iodine. Again, could be a rebound effect post-radioactive iodine. And you'll see the last thing there under treatment is surgery, like a thyroidectomy. Maybe partial, maybe complete. Let's look at our post-op care. You got to teach them how to support the neck. And what we're talking about here is they're going to have a little incision right here, right at the base of their throat. Now, do we want tension on any of our suture lines? No, we never want tension on our suture lines. So that's why we always tell people who have had this surgery to keep all of their personal stuff really close to them, like their phone, like their water, like their ice, because if they're reaching for these things, what are they going to be doing to that suture line? Putting tension on it. They're going to be stretching it. All right, positioning. What are we going to do to the head of the bed on this patient? Elevate it, right? We're going to keep that head of the bed up. Why are we doing that? Because we want to decrease edema. I don't think I want any edema right up here. Okay, it's just a little too close to my airway. That's right. Okay, so you better check for bleeding. And where are you going to look for that bleeding? Behind the neck, okay? Why are you checking there? Why are you checking back here behind the neck? Because remember, that's where that pooling can occur. Remember, pooling does not mean that blood's coming out of the body and can be seen. So you need to look and see if they have a little pouch of blood back there behind their neck. Now, nutrition, pre and post-op. You know, you always learn in school, and your teachers taught you that people always do better surgically if they are well nourished. Of course, they're going to heal better, right? But if I am hyperthyroid, am I going to be well nourished? No, because what did we say was happening to their weight? They're losing weight. So you got to look at the nutritional aspects of this client. So they're probably going to need more calories because they're burning so many. Now we have to assess for recurrent laryngeal nerve damage by listening for what? Hoarseness, right. Hoarseness and a weak voice. Y'all, this could lead to vocal cord paralysis, and if there's paralysis of both cord, airway obstruction will occur requiring immediate trach. Now, don't get me wrong. Post-op, I don't want this person talking a whole lot, but when they do talk, I need to make sure I listen very carefully, okay? Because in my nurse's notes, I'm going to make sure that I am documenting the presence or absence of the hoarseness or the weakness that they may have in their voice. You better teach them to report any complaints of pressure. That's right. I don't care if it is a teeny tiny bit of pressure. I'm going to assume the worst. Well, we're not going to say, I'm just going to watch it a little while. Just a little bit of pressure, it's okay. No, we're not going to do that. We're going to assume the worst in that situation. Now, there are several reasons why we've got to keep that trach at the bedside. First reason is swelling. Well, that's pretty obvious, right? The next one we already talked about, recurrent laryngeal nerve damage. And the last one we'll see is hypocalcemia. And we're going to talk about more of that in just a minute. Now, the next thing it says on your handout, we've got to assess for parathyroid removal. Now, how are you going to walk in the room and look at somebody and say, guess what, girl? They got them. I'm sorry. Your parathyroids, they gone. Now, how are you going to look at somebody and know that? Ask your friend how they're going to know that. Okay, it's a calcium thing. That's your hint. That's what you need to be thinking about. Because here's the deal. With thyroid surgery, there's a chance that they could have removed a couple of your parathyroids. Well, if they took out a couple of your parathyroids, then your serum calcium is going to go up or down. Which one? It's going to go down. That's right. It's going to go down. So I'm looking for the signs and symptoms of hypocalcemia. Tell your friend what those signs and symptoms are. Okay, now remember, with hypocalcemia, they are not sedated. Okay, they're not sedated. So what kind of muscles are they going to start getting? They're going to start getting those rigid, those very tight muscles. Could they have a seizure? Yes. Could they have a laryngospasm? Yes. That's why I'm keeping what at the bedside? That trach set. That's exactly right. All right, now let's look at hypothyroidism, also called myxedema. Let's look at our signs and symptoms. These people have no energy. And we know when it's present at birth, it's called cretinism, and this is very dangerous because if it's not detected, it can lead to slowed mental and physical development. So that's why they always check those babies' profiles, thyroid profiles, when they're in the hospital. Okay, let's think about the adult here. They're going to have fatigue, and their GI system's probably going to be slow. What about their weight? Is their weight going to go up or down? It's going to go up, right? You know, isn't it funny how every time your friends gain a little weight, they're like, girl, I'm going to go have my thyroid checked out. And you're like, okay, go get your thyroid checked out, and when you come back, we'll go to Wendy's like we've been doing. Okay, bye-bye, see you later. Well, guess what? It's not your thyroid. It's all those Wendy's you're going to and eating. Now, is this person hot or cold? They're going to be cold. So here's what you got to do for this. You got to tell them, I'll give you some more blankets, put some more covers on, increase the temperature in the room. Would you ever pick an answer like, I'm going to give them a heating pad? No, you're not going to pick that, right? They would love to have a heating pad, but they are so cold, they want one, but they can't have one. It's just a safety issue. So they may not be able to tell if it gets too hot. What about their speech? It is slowed and it is slurred. You know, to articulate words, you have to have energy in order to do that. You know, have you ever been so tired? I mean, you could just hardly say those words. Well, that's how they feel. They have no expression. You may be taking care of a client who is totally immobile. You know, hypothyroidism is like any other disease. You can have varying degrees of it. You could have somebody who's just a little tired, maybe gaining a little weight, but they're still able to do their work. Or you could have somebody who is so hypothyroid, they are bedridden. Now, let's think about these symptoms for just a little bit. You have somebody who's tired. They're gaining weight. They have no energy. They have no expression. That disease could easily get confused with what psychiatric illness? Depression. That's right. Well, what about hyperthyroidism? When I'm running down the hall and I'm wild with all of this energy, my eyes are bugged out of my head and I'm losing all this weight, makes you think about the patient who is manic. That's right. Why am I telling you that? Because at these psych hospitals with the admission lab work, they always do a thyroid profile. They want to make sure that you're not dealing with something that is physiologic versus psychologic. So they have to rule that out and determine which one it is. Now, let's look at our treatment for hypothyroidism. They're going to give them those meds like Synthroid, Proloid, Cytomel. Those are just some examples. Do they have to take these medicines forever? Yes, they have to take them forever. And what's going to happen to their energy level when they start taking these medicines? It's going to go up. Now, when you start giving this kind of drug, what's going to happen to their heart rate? It's going to increase. What's going to happen to their blood pressure? It's going to increase. I'm going to tell you a little secret that's right here. Hypothyroid people tend to have CAD, coronary artery disease. Why? I don't know. It's just you see them in the books, and we just have to accept that that's the way it is. We just have to accept that hypothyroid patients are going to have coronary artery disease. Well, the reason I'm telling you this is because when you're in the hospital and you're giving somebody Synthroid IV push and their heart rate goes up, blood pressure goes up, I'm going to be aware for any complaints of chest pain or any rhythm changes that my patient might have. Okay, let's look at our parathyroid. Now, anytime you see the word parathyroid, there only should be one electrolyte that pops into your mind. What is it? Calcium. That's right. See, they think when you see that word parathyroid, since it has the word thyroid in it, you're going to start thinking about all that iodine stuff. And we know that parathyroids are totally different from your thyroid. So, you and your friend, see if you can fill in those blanks all the way down to the end of the page, okay? Go, fill them out. Now, let's see how you did. Parathyroids secrete what? PTH, which makes you pull calcium from the bone and place it in the blood. Therefore, my serum calcium is going to go up. If I have too much parathormone or PTH in your body, serum calcium level will be high because we know PTH makes serum calcium go up. Now, if I don't have any parathormone in my body, the serum calcium level is going to be low. That's right. So, let's look at hyperparathyroidism. We see it's the same thing as hypercalcemia, same thing as hypophosphatemia. Signs and symptoms that we see here, they have too much PTH, serum calcium is going to be high, serum phosphorus is going to be low, because we already said in fluid and electrolytes, they have what kind of relationship? They have that inverse relationship. So, anytime you see the word hyperparathyroidism, think about hypercalcemia. It's the exact same thing. Now let's look at our other signs and symptoms that you see there. What do you think they're going to look like when their serum calcium level is high? They're going to look sedated, right? Because we said calcium acts like a sedative. So I want you to write sedated out to the side there. You know what this patient looks like, right? They are going to be sedated. Now, let's look at our treatment. Partial parathyroidectomy. In other words, they're just going to go in and take out a couple of your parathyroids. Now, when you take out a couple of those parathyroids, PTH secretion is going to decrease. When you do that, are you going to be making as much PTH? No, you're not. So naturally, that serum calcium is going to come down. And after surgery, we want that serum calcium level to come down to a normal range. But what could happen? It could bottom out, right, and become hypocalcemic. That's what I'm worried about post-op. I'm scared my patient is going to bottom out and become hypocalcemic post-op. So tell your friend what kind of signs and symptoms you're going to be looking for in your patient after they've had a parathyroidectomy. Remember, our patient is not sedated, so I'm going to be looking for those rigid, tight muscles, okay? Now, let's look at hypoparathyroidism. Hypoparathyroidism is the same thing as hypocalcemia, which is the same thing as hyperphosphatemia. So, our signs and symptoms, not enough PTH, so our serum calcium is low, serum phosphorus is high. Other signs and symptoms, our client's not sedated, okay? The client is not sedated. Treatment, one of the things that we said yesterday, when you have a patient who has hypocalcemia, you need IV calcium. So write that down, IV calcium. We also talked about several drugs that we can use to help you increase the calcium. You remember those phosphorus binding drugs like Renagel, Boslo, or even Oscal? Remind your friend how those drugs are going to work. They are phosphorus binding drugs. So when I bind with phosphorus, it's going to make my serum phosphorus go down. Well, that was kind of sneaky, all right? Because when you did that, that made my serum calcium go up. But that's what we want. That's exactly what we want. Now, we're switching gears and we're going to look at our adrenal glands. You have to have those adrenals in order to handle stress. And we have two parts of the adrenal gland, the adrenal medulla and the cortex. First one we're going to look at is the adrenal medulla. This is our epinephrine and our norepinephrine. And we've already talked about how epinephrine and norepinephrine make us feel. So let's talk about our adrenal medulla problems like phenochromocystoma. We know that these are benign tumors that secrete epinephrine and norepinephrine in boluses. So let's look at our signs and symptoms. Guys, if I gave y'all a big bolus of epinephrine and norepinephrine, what's going to happen to your blood pressure? It's going to go up. Heart rate's going to go up. That pulse is going to increase. They're going to become flushed. They're going to become diaphoretic. Let's look at how they diagnose it. You come in and you're holding your head and you're telling your friend, you got to take my blood pressure, okay? Take my blood pressure. It's up, my heart rate's up, my head's killing me. So yeah, they check it, your blood pressure's up, then it goes away. Well, you start having some episodes, okay? And you're concerned about these episodes that you're having, so you go to the doctor and you tell him what's going on and give him the history of your signs and symptoms. And based on that history, the doctor's going to do a VMA test or a vanilla mandelic acid test. Now, look at the name of that test. What food might alter that test? And it's not a trick question. Vanilla. Anything with vanilla in it. Well, that's great. Now I got to know how to cook to pass the test. Well, how long do they need to be off of this? They need to be off of it for about a week. Okay, they need to be off of it for about a week. Now, the VMA is a type of urine test. So what kind of urine specimen are we going to need? We got to have a 24-hour urine, 24-hour urine. And they're looking in that urine for those increased levels of epinephrine and norepinephrine. That's what they're looking for. So now I got to teach my client how to do a 24-hour urine. Now you know with a 24-hour urine collection, you've got to do what with that first void? Throw it away. That's right. You're going to throw away that first void and you're going to do what with the last one? You're going to keep it. So you throw away the first, keep the last. So you collect and you collect and you collect every little bit of urine that they have for that 24-hour period. You know, your teacher told you if they missed one little cc, they had to start all over again. Well, let me ask you a question. Why can't, when I go to the doctor's office, why can't I just have a urine specimen done there? Why can't they just get a urine sample there and check it? Check it for that epinephrine and that norepinephrine. Ask your friend, why can't they just do a regular urine specimen? Well, while I'm at the doctor's office, I might not be having one of those episodes or those spells. I might not be getting that bolus of epinephrine and norepinephrine when I'm in the doctor's office. You don't know when it's going to happen. Now, before we move on, I want to talk about something. Aren't there some other things out there in the whole wide world that can make you have those surges of that epinephrine and that norepinephrine? Yes. What about the day I start collecting my 24-hour urine specimen, I have a screaming, fit-pitching, good old PMS fit. Okay? What's going to happen to my levels of epinephrine and norepinephrine? They go up. Well, what if I get bored when I'm collecting my 24-hour urine specimen and I decide to go down to the Circle K and get me a carton of cigarettes, gonna start smoking. So here I am, smoking with my big old pack of Marlboro Reds what's going to happen to my epinephrine and norepinephrine? It's going to go up. What if I decide I'm going to go out on a 3-mile run? And here I am running. Got my urine collection because I can't miss any, right? What am I going to get surges of? Epinephrine and norepinephrine is going to go up. So these are things you need to teach your client. You need to teach them these things. So the day that they're starting their test, they need to be as calm as they can be and try to avoid that stress. Let's look at how we're going to treat the problem. That's easy. They're going to remove the tumors. Now, let's look at the adrenal cortex. When you think about the adrenal cortex, you should be thinking about those glucocorticoids, mineralocorticoids, and those sex hormones, right? Those are just fancy words for steroids. And there are different types of steroids in the body. But when you're giving a steroid to a patient, whether it's a shot, whether it's a pill, whether it's IV push, you need to know what type of steroid you are giving, right? Right. You need to know what kind you're giving because you need to know what action you're going to be looking for. Because even though we secrete those steroids normally, the adverse effects are more pronounced when they're receiving these steroids through an oral pill or through IV steroids that they're getting. Probably the most common steroid that we're going to be given is going to be those glucocorticoids. And we're about to go over the 4 major actions of glucocorticoids. And you got to know these 4 actions because if you don't know these 4 actions, you're going to always miss those steroid questions, okay? You're going to miss Cushing questions and you're going to get messed up on your Addison's disease too. So let's look at the 4 major actions of glucocorticoids. First one is they change your mood. You know, when your client's on prednisone, Solumedrol IV push, they just start acting crazy. They may act depressed. They may become psychotic. Some people even become euphoric. They love the way it makes them feel. So they don't want to stop taking them. So in other words, you have more and more energy with some patients and they're getting all their work done. But steroids can also cause the patients to have what? Insomnia, okay, where they're not sleeping. So mood changes can present themselves in many different ways when they're taking steroids. You can have somebody who's never ever been depressed before in their life. You give them a shot of Decadron LA, you know, the long-acting one, they can go into a major depression and have to be hospitalized for depression. Most of the time, you know, people just get mean when they're on steroids. You'll have a wife call the doctor's office and she'll say, whatever that was that you gave my husband, please don't ever give it to him again because he has just been mean for the past month, okay? Thank you very much. So, different kind of mood changes that you'll see. The next action that we're going to see here is altered defense mechanism. Everybody knows that steroids do what to your immune system? Suppress it. Well, when you do that, I'm at risk for infection. So when you're making those room assignments, does it matter that your client is on steroids? Absolutely, because they are going to be immunosuppressed. Now, another action that we'll see here is steroids can also make you break down fat and protein. You'll see what we're talking about when we look at the man with Cushing's syndrome. Because a Cushing's client, they're going to have those skinny arms and legs. They're breaking down that protein and fat. And we know that children who are on steroids don't grow correctly because what are they breaking down? They're breaking down that protein and fat. All right, the last action that we see there is steroids also inhibit insulin. Well, if it does that, now my blood sugar is going to go up. They're hyperglycemic. You know, anytime you have somebody in the hospital and they're taking steroids, you're going to be doing those Accu-Checks. You're going to be doing those finger sticks because they may need some insulin. All right, those are the 4 major actions of glucocorticoids. Now, I want you to take just a second and discuss those 4 actions again with your friend. Okay, now let's move on and we're going to talk about those mineralocorticoids. Aldosterone we see is the major mineral corticoid. We know aldosterone makes you retain what? Sodium and water. Well, today we're going to add a new sentence. It makes you lose potassium, okay? Makes you lose potassium. Okay, now tell your friend, if you have too much aldosterone, what is going to happen to the vascular space and the serum potassium? If you have too much aldosterone, you're going to retain sodium and water, and you're going to lose that potassium. So I'm going to go into a fluid volume excess, and my serum potassium is going to go down. That's right. Now, tell your friend what's going to happen if I don't have enough aldosterone. I'm going to lose that sodium and water, and I'm going to go into a fluid volume deficit. And my serum potassium is going to go up. So now I'm hyperkalemic. All right, we're going to talk about the sex hormones when we talk about Cushing syndrome. But look at the box right there that you see. We just want you to know that there are different words that they'll use for steroids, but for NCLEX, they are all fancy words meaning the same thing, steroids. So make sure you read over that when you're studying, okay?